everybody. Welcome to our presentation. Today's presenter is Dr. Karabo Mahuma. She's a young chemical pathologist, part of the dynamic team at Pathcare. She obtained her MBCHP from the University of Pretoria in 2014, followed by her internship and community service in Limpopo, where she gained valuable experience during her subsequent time as a medical officer. Her interest in laboratory diagnostics later propelled her to obtain her specialist qualification from the Colleges of Medicine of South Africa in 2023 and her M.Med from the University of Pretoria in 2024. She is enthusiastic about bridging the gap between clinicians and laboratory personnel in pursuit of quality healthcare for all patients. Thank you so much.
Good morning, everyone. Thank you for the introduction. The title of my talk today is Breaking Down the Breakdown. Hopefully it will make sense as we go on with the talk. So the content of my talk today will include a brief introduction, overview of pathophysiology, some clinical findings that we would expect in patients that present with rhabdomyolysis, an overview of causes and an overview of lab investigations and associated complications, and also the purpose of this talk. And I think you, as our colleagues, are probably very well versed in treatment, so it will be just a treatment overview in terms of this. So firstly, introduction. From the name, we can see that basically, at the core, it's just breakdown of striated muscle. But what causes this to be of importance is that the syndrome is characterized by significant skeletal damage and breakdown and necrosis of muscle tissue that results in release of intracellular contents into the bloodstream. And it's said because muscle forms about 40% of our body, we can imagine the catastrophic effects that would occur with extreme skeletal damage. So just a few definitions. Crush injury or traumatic rhabdo refers to the direct injury to the body, trunk, limbs, for example, caused by extensive external compression, and this leading to ischemia and as a direct effect of this pressure. There's also a consequence of release of pressure, which is almost counterintuitive, that when you relieve this pressure, there's this associated swelling, and therefore necrosis that will result as a consequence to this. Crush syndrome, rather, is this umbrella term defined as the systemic manifestations that result from crush injury, and these would include particularly what interests us is, or what we dread is that acute kidney injury, but it can affect other organs, and also it's life-threatening, so it can result in death if not treated adequately. So just a brief overview of history. So long ago in the Bible records a plague that was suffered by the Jews, and as they went from Egypt, and it said that they suffered and had what we would now term as rhabdo after consuming large amounts of quail, and it said that the quail actually had ingested hemlock seeds, which are said to perhaps cause rhabdo. In 1881, German literature has the first reported case of rhabdomyolysis. And then in 1941, Bywaters and co-workers established a relationship between muscle necrosis and brown pigment. So what they did, they described 4 patients that had crush injuries buried in rubble, and with the clinical manifestations, they had swollen limbs and this discolored urine and developed shock, and this was introduced the term a crush syndrome, and these 4 patients died within a week, and the autopsies are the ones that reveal this brown pigmented tubular pattern in the renal tubules. And taking a look at epidemiology, so the incidence varies with the various etiological causes. There's limited data because of how studies in terms of patients presenting with because it can range between asymptomatic or mild increases in your muscle enzymes. So there's limited data in that, but one can associate the incidence based on the different causes. Body mass index is a huge part of these patients that are at risk. So most of these patients with increased morbidity of or increased BMI would probably also be on statins, for example, and that just adds to, or would be exercising, and therefore making them prone where they have unaccustomed or excessive exercise in an attempt to lose weight, for example. So these patients are patients that we should consider at risk. There's also frequency in specific populations. So in our athletes and in trauma patients, trauma being a huge cause of what you guys probably see in casualty related to trauma injuries or heat injuries. And patients who are can occur in all age groups and both sexes, but we do see that depending on the age, we can think of different causes. For example, in children, we would think more infectious causes, and in adults, we are looking for either drugs or trauma-related or exertional causes as part of the incident. So taking a look at pathophysiology, so at the core of rhabdo, this involves either a direct myocyte injury or a failure of energy supply within the muscle cells. So to maintain adequate function of skeletal muscle, we need an intact or good integrity of your myocyte membrane. We need ATP, adequate metabolism of ATP, and electrolyte exchange. And this becomes important when in the next slide, where I'll be showing just the different channels that are involved in maintaining this homeostasis. So basically, the muscle injury will result in this massive release of all your intracellular contents, and therefore that is what you would look at when you work with in this patient. So from this picture, I'm not sure if it projects well, but basically you have two pumps. So injury or anything that causes a decrease in ATP would result in your sodium, potassium, ATPase pump not functioning well. So normally this pump is responsible for pumping sodium out and potassium, maintaining increased intracellular potassium, and therefore creating this negative gradient that allows for calcium to be taken out of the cell and sodium to be brought inside the cell. So when these pumps are not functioning adequately, you find that there is increase in intracellular sodium and increase in intracellular calcium, and this increase in intracellular calcium is responsible for what you see protease activation, and therefore this degradation inside the cell and damaging the cell. It's also what it also does, these free radicals that cause mitochondrial damage and apoptosis and muscle destruction. So this is just to further iterate what we were saying, just to emphasize as well from this slide, is that there's also the effect of unaccustomed physical exercise. So patients who are exercising too much too quickly may also have injury or direct injury to your sacroiliacal injury. And then this increased cellular permeability of sodium. Remember, we know that sodium also attracts water. So increased intracellular sodium resulting in edema in these cells, actually compromising their integrity or membrane integrity. The failure of energy production due to dysfunction of, and we'll see later in the causes, any electrolyte imbalance that can cause dysfunction of these pumps that we just previously saw. That increased intracellular calcium concentration is what activates your proteases that are calcium dependent, and this resulting in the destruction. So all of this is we can see the fine balance that is maintained by these pumps, and we can think of any cause that can elicit changes will result in dysfunction of these pumps and therefore may elicit rhabdomyolysis. So how do these patients present? Generally, there is said to be a classic triad of myalgia, weakness or swelling, generally on your proximal muscle groups, and dark urine that is discolored. But of note that this triad is said to only be observed in less than 10% of patients, so it's not something that we will see in every single patient. There may be skin changes, there may be oliguria that these patients have. So there's a range of severity in the symptoms and how these patients present, making a high index of suspicion quite important for these patients. So as we said before, any condition that would increase metabolic demands and more than what is the available supply of ATP, or any extensive muscle damage or extreme exertion, or any condition that would cause an influx of extracellular sodium and calcium into the myocytes would cause problems. So looking at traumatic or direct muscle injury causes, even states of immobilization where you have this unrelieved pressure on different areas. They're said to be patients who develop gluteal compartment syndrome simply from being immobilized for long periods of time. And also the importance of mechanical but also thermal injury and any injury that would cause ATP depletion. So patients who are at who have extreme heat for whatever reason, perhaps also exercising for very long, too long, strenuously, so the body cannot go for very long at a temperature of more than 40 for more than 8 hours. So some patients that have whatever cause that may cause high extreme temperatures in the body would result in thermal injury and therefore cause rhabdomyolysis. So the other different exertional causes, non-traumatic, these are non-traumatic, but also there's also what we should also consider metabolic myopathies, and these are other, we will look into some of the causes into more detail. Non-exertional causes, and a huge part of it is drugs or different substances. Ethanol, for example, has direct adverse effects on the muscle and affecting tissue metabolism and therefore cellular integrity, and also inhibition of those active transport pumps. And your cocaine and your heroin, all these implicated as well in all of these also implicated in rhabdomyolysis. We'll also look at some infections, so I'm going to go into more detail into some of them. So some of the drugs we were speaking about last week or the other week about patients refusing to take statins, for example, because they're so scared of them developing rhabdo, but I'll also go into that in a bit. But other drugs as well, psychiatric medications that may cause rhabdo, and we'll also look into that. And illicit drugs we already spoke about. I wanted to just touch on something that I also found interesting about propofol infusion syndrome, patients that have this propofol toxicity and therefore an uncoupled oxidative phosphorylation in your mitochondrial electron transport chain. And this causing all these systemic manifestations, including rhabdomyolysis. So just to touch more on statins. So statins being HMG CoA reductase inhibitors. So it said that rhabdomyolysis, although this is not generally a lot of patients will experience some muscle pain after, but these patients are patients that develop rhabdo usually would develop after 2 to 3 weeks after initiating therapy. And although the mechanisms are still not quite clear, but what is said to be suspected to be the cause of why statins do this is that there will be myocyte mitochondrial dysfunction because of it, disruption of cellular respiration, and impaired calcium homeostasis. There's also induction of apoptosis that results in some patients that have this immune-mediated necrotizing myopathy. These patients will have anti-HMG-CoA antibodies. So statins commonly would cause a toxic myopathy that may not be necessarily associated with muscle necrosis, and these patients will generally present with a CK of less than 1,000 units per liter, and really the autoimmune myopathy where it's even increased levels with associated muscle necrosis in these patients in which they have that. This diagram, it's just to explain what, as I said before, the exact mechanism is not yet clearly understood, but what is said to perhaps be contributing to this is that your coenzyme Q, which is a huge component of the mitochondrial respiratory chain, so it acts as a mitochondrial electron transport facilitator. So with the use of statins, where you are have this statin accumulation and therefore decreased cholesterol and decreased mevalonate, which is responsible for calcium signaling. And therefore, as we saw previously in the previous diagrams about the effect of calcium and how that would result in activation of different proteases and therefore causing necrosis. And this coenzyme Q10, I've seen it in lotions and products, but clearly here the decrease of it would result in a decrease in energy cellular production in the mitochondrium and therefore also resulting in necrosis. So you have this disruption of your energy production and therefore causing a compromised integrity of your cellular membrane and therefore necrosis. So it's this finding, and I think it's something to highlight, is that there's such a risk, although it's not common in, or it's not every patient that will develop adverse effects to the extent of rhabdomyolysis. There's also increased risk that one has to consider in terms of concomitant use of other medications, especially cytochrome P450 inhibitors or corticosteroids, or patients who actually have concomitant renal or liver insufficiency. On top of this, that these patients may develop adverse effects. And also there's the dose-dependent manner of damage. So an increased patients who are obviously getting greater doses will have a greater risk of developing rhabdo. And then the clinical advisory on statins defines statin-induced rhabdo as muscle symptoms with a marked CK elevation of more than 10 times the upper reference limits and is accompanied by creatinine elevation as well as myoglobinuria. So vivo and in vitro experiments have revealed that lipophilic statins or your simvastatins are more likely to produce actual vascular effects relative to the hydrophilic agents. So lipophilic agents are metabolized by the CYP3A4, which leads to competition of other drugs. And this increases statin levels and therefore predisposing this patient to toxicity. While your fluvastatin, for example, is metabolized by your CYP2A9 isoenzyme and therefore carries a less risk of drug interaction. So your lipophilic statins increase all cell disruption through apoptosis and proteolysis, and this, therefore, these statins can easily pass through the lipid layer and cause damage. So, as we said, there's a greater risk with concomitant use of drugs that also inhibit cytochrome P453A4 or CYP3A4, so different antibiotics, antivirals, protease inhibitors in your RV patients, and calcium channel blockers that patients may be on, and other drugs like amiodarone that can also have an increased risk when concomitantly used with statins. So these are just other risk factors for patients that if there's any use of statins, but also these patients are at risk of being more susceptible to developing a rhabdomyolysis. We spoke about the effect of our drugs, so antipsychotic agents that may cause neuroleptic malignant syndrome, so a massive generation of heat that is caused by rigidity and tremor. So these patients may also be at risk, or malignant hypothermia patients, so patients who, as a result of anesthetic drugs, develop these all these skeletal rigidity and hyperventilation and systemic effects of fever and hemodynamic stability. So these patients also can be attributable to this. Electrolyte imbalances, so a causative, something that has to be excluded. Hypokalemia, so as we saw from the previous slides where we looked at the different pumps, hypokalemic state can cause rhabdomyolysis, and what happens is that there's dysregulation of arterioles and reduced blood supply, so basically a hypoperfusion to these muscles, and the suppression of the synthesis of glycogen. And there's also deranged ion transport across these cell membranes that results in patients being prone to developing rhabdomyolysis. And ATP depletion as a result of hypophosphatemia results in the inability also of muscle cells to maintain membrane integrity and making them prone to bursting, and therefore having this extensive muscle necrosis. Infections, what we would normally consider in your pediatric cases, and something to exclude. So various bacterial, viral, or fungal infections that can cause, and the proposed mechanisms of it is that they may be direct invasion of the muscle that causes this, or activation of lysosomal enzymes or endotoxins, or tissue hypoxia that happens as a result of these toxins, and therefore leading to rhabdomyolysis. Hypothyroidism, so although rare, evidence does stipulate that in hypothyroidism patients that develop rhabdomyolysis, there is generally an evidence of another precipitating factor like exercise trauma or drugs or statins or alcohol also contributing to this. But the mechanism is said that because of a lack of thyroxine, these patients may have impaired mitochondrial oxidative processes, and therefore glycogenolysis that is also impaired. Dysregulation of your metabolic pathways, such as your Krebs cycle, which is important, your fatty acid catabolism, and your glycolytic energy production. So as a result of this, but this is, I'm not sure how commonly you guys see this, but it's said to be quite rare. And then just to cover as well, also even more rare, the hypothyroidism as a rare cause of as a result of increased metabolic rate and muscle wasting. So these patients may develop that. Patients that have adrenal insufficiency, whether primary or secondary, but the result is, or the basis is that the deficiency in cortisol that has mineralocorticoid activity, and then can lead to various electrolyte imbalances. In your DKA, for example, all the metabolic derangements that we see in your DKA patients that will contribute to your rhabdomyolysis. Just to cover, there is a possibility of inherited causes or susceptibility to rhabdo in metabolic myopathies or patients with muscular dystrophies, and these should be evaluated if there's not really a cause that we can see from the history or physical examination or initial laboratory results. And what is important is definitely the presentation of them and the chronicity of it. There may be subtle differences in the different manifestations of the metabolic myopathies. But for example, in glycogen storage disease, where there is a history of exercise intolerance or patients having recurrent cramps, and when one can request, for example, an ischemic forearm test that we do in our lab, where we measure lactate, the response of the body to this ischemic event. So a failure of lactate to rise in an anaerobic environment, what is supposed to happen is that lactate will now become the main focus, or pyruvate will proceed to glycolysis, only proceeds to lactate during this ischemic event, and ammonia rises as a result of any amino acid deamination. So in patients that have these glycogen storage disease, there will be a failure of lactate to rise sufficiently, or for example, in your McArdle's disease, where these patients will have a failure to rise of lactate, but also they may also have a normal exaggerated ammonia response, any defects of glycolysis as well. If they're patients that have a failure of ammonia to rise sufficiently with a normal lactate response, there we would think of your myoadenylate deaminase deficiency. If they perhaps is an exaggerated ammonia response, and in these patients, even with a normal lactate response, one would consider your McArdle's disease, but also muscular dystrophy or mitochondrial myopathy. Patients that would present or complain of having recurrent episodes of rhabdo after exertion, or especially in association with fasting or viral disease. So your CPT deficiencies, one should consider, and acyl carnitine profiles can be conducted for that. So mitochondrial myopathies, we spoke about that, but also any structural muscle disease that may occur. And then your autoimmune and inflammatory myopathies, these inflammatory myopathies such as dermatomyositis that will present with myalgia and these elevated CK. Important of note is that the systemic effects of autoimmunity, for example, these patients perhaps presenting with rashes may be a clue to this. These patients will have muscle weakness, elevated CK levels, but and if a muscle biopsy is done, lymphocytic infiltrates will be demonstrated, but the chronicity of disease and the prolonged duration of these CK increased or elevated CK laboratory abnormalities is what would make you think of a more autoimmune, especially if it's not responding to treatment. So, for example, in affected patients where there is no improvement, but these patients actually improve on, affected patients may require immunosuppressive therapy to control their disease. So it just highlights the importance of history and how they present, that even though they may present with elevated, and if there's no trauma or acute acquired cause that can be elucidated, then we can suspect these. So patients on statin medications may develop an immune-mediated necrotizing myopathy, and these patients will respond to immunosuppressive therapy and immunomodulatory therapies. And as we said before, these patients, currently this is not offered as far as I know. I'm not sure about other labs, but I know we currently do not offer this. But in patients that have this necrotizing myopathy, illustrating this would be contribute to the diagnosis of this. So just going into laboratory investigations, so your creatine kinase is the most sensitive indicator that we have and generally widely used. It also has the advantage that in patients in our setting that perhaps may present to, in comparison to myoglobin, that quite early, but is said to decrease quite quickly. CK remains elevated quite for a longer period of time, and therefore making it a very useful tool in our setting. It is generally accepted that an increase of 5 times the upper limit of normal is considered as the as defining, or a value of more than 1,000 units per liter. As I said before, chronic diseases like inflammatory myopathies and muscular dystrophies may reach these levels, but however may present quite differently. So clinical correlation for this is quite important. So following muscle injury, myoglobin increases quite rapidly, cleared quite quickly, and a normal level would be reestablished. So the serial monitoring, preferably of CK, is recommended. It correlates quite well to the degree of muscle injury, and although not well in the terms of development of acute kidney injury, but it's a good reflection of how extensive your muscle injury is. So this is just a table just to show prognostication of what you would think in patients in normal CK levels between 40 and 200, and this may vary with age and with sex as well. Mild rhabdo and with severe rhabdo being more than 15,000 in these patients, it's said to be a greater risk of an acute kidney injury that you would find between the moderate and severe levels of CK. So myoglobin, as we said, it peaks within 12 hours, while CK only reaches at 24 to 72 hours, and it normalizes quite quickly while CK remains elevated following the insult. So the expected clearance of this is, however, dependent on renal function and the integrity of that. So whether ongoing muscle damage is present and whether there's actual management or intervention that is incorporated. So it has a short half-life of 1 to 3 hours and may return at even as quickly as 6 to 8 hours. So myoglobin, as much as we do see requests for both, but it's just important to note that timeline in terms of serial monitoring. So these patients that develop, so what you would find, either you would find a hypokalemia or hypophosphatemia as the causes, but as a result of this massive muscle degradation and release of this muscular contents into the bloodstream, these patients may have life-threatening hypokalemia, which is a condition. We're thinking that we would monitor it with ECG findings to detect any abnormalities in relation to these. So these patients may have severe arrhythmias that may result as this. So this is important to monitor. And the resultant hypophosphatemia, as we said, everything going out, the dysfunctional ATPA, those pumps causing hypocalcemia, but also this hypocalcemia as an initial complication. But as a result of the influx of calcium intracellularly, but also in patients that, as a result of the high phosphate, that may result in calcium phosphate precipitation. Hyperuricemia as well. So we'll see later on when we look at acute kidney injury, the effect of this acidic environment that it makes it conducive for AKI to develop. So these patients will have obviously increased urea and creatinine in terms of their renal function, and then high iron gap metabolic acidosis as a result of accumulation of phosphates and organic acids. Liver derangements may also be part and parcel of what you would see, and with your hematological studies, so there would be prolongation of your prothrombin time, thrombocytopenia, and high levels of fibrinogen degradation products as a result of this. So this is what you would see. So in terms of your rhabdomyolysis-induced AKI, so it's said that 10 to 40% of patients with rhabdo actually develop it, and it's also a cause for up to 15% of cases of AKI. And the different, we will see in the next slide, but the different mechanisms or what is suggested to be contributing to this injury may be as a result of hypoperfusion or a direct ischemic tubular injury or tubular obstruction. So this is just a diagram just to show what we were saying earlier, just to highlight what we're saying in terms of the different markers and when they would rise, and therefore giving us an indication of when serial monitoring would be would be effective. So this diagram just showing the effect of myoglobin. So myoglobin being heme containing. So in the effect of rhabdomyolysis, you have these contents of the muscles that are put into circulation, and therefore they have direct toxic effects on your capillaries, and these capillaries obviously are damaged, and there's leakage and edema. So this fluid sequestration and depletion of intravascular volume would result in decreased renal perfusion as a result of activation of your renin-angiotensin system, as well as your sympathetic nervous system, all favoring the patient to have vasoconstriction and to retain water and salt. And in this, the presence of dehydration and renal vascular constriction, obviously the tubular flow will decrease and water reabsorption will increase. We were speaking earlier about the increase of, for example, uric acid that creates an acidic environment. So the acidic environment makes it a perfect environment for your myoglobin to bind or precipitate with your TAM protein. So this is a protein that is, so basically this process is precipitated by acidic urine. So tubal obstruction occurs principally at the level of the distal tubules. So this protein, which is found frequently in human urine, so its precipitation of myoglobin is accelerated at lower urinary pH. So this causes this precipitation with your TAM protein causes direct tubular injury and therefore causing oxidative cell damage and cell damage to the renal tubule. So tubular obstruction and cast formation that as a result of this precipitation. And because myoglobin releases heme, this results in free radical formation, and this is said to have a direct ischemic effect, direct and ischemic effect on the tubules and therefore injury. So this McMahon score of that is said to be a good, is validated as a scoring system to predict those that are higher risk of requiring renal replacement therapy. So in patients that have a score above 6, so in these patients that have a score above 6, so it's said that this gives a better or greater sensitivity in comparison to CK levels that are increased, even though they increased quite high. So this score would incorporate based on the different parameters that you see, taking into consideration the age and sex of the patient, creatinine, calcium, CK levels, as well as if there's any causative thing that you could elicit from the history, and serum phosphate on admission. So we can see that it just further emphasizes, gives us an idea of patients and their need for renal replacement and obviously their prognosis as well in terms of this. So this is a useful tool to use. We spoke about the injury, all these sequestration of fluid. So these patients may actually have a dysregulated inflammatory response that will lead to massive capillary leaks and intravascular depletion, and therefore vasodilation and circulatory collapse. So these patients, this could be as a result of also contributing to this may be pro-inflammatory cytokines that result in decreased myocardial contractility. So this is just a diagram to just kind of highlight those complications that we were talking about. Heme releases various prothrombotic substances like your thromboplastin, and therefore from the destroyed muscles, and this activates your coagulation cascade, triggering the syndrome of DIC. So widespread clot formation and platelet depletion. We spoke about hypokalemia that may result. So these are your early complications with your hypophosphatemia and your hypocalcemia. Of note that late complication that would be hypocalcemia, but now hypercalcemia in the late course of the disease, where there's efflux from the damaged muscles. As we said before, there's increasing intracellular calcium. So these damaged muscles would release all this calcium into the bloodstream. And if there's also concomitant slow clearance, then these patients will actually have this. We spoke about hypovolemia, but compartment syndrome as well, with the swelling of all these muscles in quite tight fascial compartments that may need to be relieved, and this causes severe muscle ischemia and fluid sequestration that results in swelling. So just an overview of treatment. At the core of treatment is to really prevent your acute kidney injury. That's what we want to at the basis of it. So aggressive IV hydration is important, and this is important in reducing renal vascular vasoconstriction, as we saw in the previous diagram on the pathophysiology of how myoglobin or rhabdomyolysis contributes to the kidney injury. We want to maintain adequate urine function, or urine output rather, in these patients. So prompt aggressive fluid resuscitation is important in that. Alkalinization of urine with crystalloid resuscitation is also considered to be part of management, and the use of bicarb and mannitol is recognized. However, just observational data suggests that they provide not necessarily any additional clinical benefit. I think it would be interesting to hear what you guys have found in your practical clinical experience. The management of electrolytes is important, as we saw the causes of electrolyte imbalances that cause rhabdo, and also what would be as a result of the rhabdomyolysis. So it is important to identify and treat the underlying cause, whatever it may be, because prognosis varies. And as we said, urine output is quite important in monitoring these patients. And obviously, what we would dread in patients that have severe AKI, these patients would obviously have to undergo dialysis. So basically, treating complications in patients that develop compartment syndrome, for example, fasciotomies may be necessary in these patients. But this is just in conclusion on this topic. So you have your diagnostic criteria. Obviously, the patient will present with a specific history or something that you may be able to, symptomology that you may be able to elucidate. There may be elevated CK, obviously the laboratory investigations, and changing color, although this is not something that you will find in every patient. So in patients that perhaps they have a dystich that points to blood, but when the high field microscopy is done, they will be less than 5 red blood cells. So we then can say that there's myoglobinuria. But because, as we said, how quickly myoglobin is filtered, this may not be something that you always observe. But in combination of all these findings and having a prognostic score that will give you an indication of how to proceed. So in patients that have a very high CK, patients may tend to have acute kidney injury. So thank you for your attention. I hope you're not too tired from all of this. And these are my references.
Thank you so much, Karabo. This is really, for me, you just took a elephant or bull by the horn and is cleaning properly. And I think the problem of the rhabdomyolysis is just a very wide, extensive topic that, it's difficult sometimes, to actually break it down. But I think you went in every small details. And I probably learned quite a lot of few things, especially about the score. We have always looked at the CK levels of more than 50 to 100,000. That's when we actually start dialysis. I didn't know that there was a score, but I think because it's not enough time to read. So I think quite there are a lot of good details, and I think perhaps we could actually, for ICU in the past, we have used what we call rhabdomyolysis regime, okay, just to kind of treat them. But I think that's what, those based on previous, but always made medicine, obviously with time, everything improved with time. So I think maybe we can actually start drawing guidelines how to manage our patient with the rhabdomyolysis. And the take home message probably two things. One is that you look at the underlying cause. If the electrolyte, you need to replace urgently, and the two electrolytes really are calcium and phosphate that play a role. But I think probably perhaps magnesium, sodium, some extent, but they've got ascertain that. And then also, I mean, we also see a lot with them. Most patients actually with rhabdomyolysis, some of them probably present with what we call high trop T, because people don't do CK nowadays. And they find that thing at 300-400, and then they go for angiogram, and then find that they actually got normal coronary arteries, and sometimes then they're discharged. While actually, ideally, they could have done the total CK, because once your CK goes high, your trop T also increases because they're all muscles. So it's not specific that actually the trop T is really more cardiac, but because myocardium also got the muscles in there. So I think that's sometimes what we are picking up. So I think for patients that go for angiogram with negative high trop T, you need to do CK levels and obviously do that. Yeah, but I think my globin actually has fallen out in really kind of in the past. We look for microglobin more than 1,000, 10,000, but as you say, the half-life is really short. So it really, again, I don't think it's a proper Kita used to tell us that actually it's not specific to diagnose rhabdomyolysis using microglobin. You should be looking at the CK because it's a specific muscle enzyme. So that for me, at the moment it's more than 50, 100,000 dialysis. You don't need to wait for kidney failure. You must dialyze a bit earlier as compared to when it's less than 50. And then you go for fluid, and one with the fluid, of course, you give a soda calf infusion and with a bit Lasix to kind of improve them. And we also see them quite a lot in people that do a lot of heavy gymming training using anabolic steroids, and that they will have a high level of CK levels. And CK is known to be toxic to the kidney, and with time to actually develop acute kidney injuries. We see them in our practices, and sometimes you really have to discourage them to decrease their exercise or perhaps hydrate quite a lot. But really, for me, it's a nice, exciting presentation and something that one day, when I'm driving, it's nice to listen to it. But well done. Any questions, guys?
I just have one quick question. Did you come across anything in your reading that shows any benefits from supplementing coenzyme Q in patients with myalgia and symptoms related to statins?
That sounds like Agnes' question. You did.
So the cardiologist prescribed it, and I've seen it, and I've prescribed it as well. So especially because you buy it over the counter, and you tell patients, if they start developing muscle, they can use coenzyme Q10. So it does help.
I think there's some benefit from it, or maybe it's the doctors feel good.
Almost placebo.
Exactly. Doctors don't have to give something. Yeah.
Because I guess those substances are not regulated.
Yeah.
100%.
So you find like a good response?
Yeah, so it's better to give it and let the patient continue with the statin than the patient stopping the statin.
Yeah.
So because people like taking vitamins and supplements now, so they don't have a problem taking coenzyme. So
Okay, guys, thank you. I think we can leave the presentation. I understand there's a lovely thing waiting outside. Thank you guys for joining. Any question, Dr. Okoli? Anybody out there?
No question from my side. Good morning.
No question.
All right. Well, thank you for joining us always. I think we just need to see, we need to get you a CPD points because you've been quite attending so you can access them. We're still working on the process to establish it. Then you can access your CPD points. Thank you.